progresser vers la session 2, qui comprendra 3 présentations. Et la première va être animée par Dr Dubé. Bonjour, je suis un ancien de l'Université Laval, donc c'est toujours intéressant de rencontrer un professeur de l'Université Laval. Dr Dubé est du département d'Anthropologie de l'Université Laval, comme je le disais tantôt. And since 2008, Dr Dubé is a researcher in a scientific group on humanization at ce qu'on appelle l'INSPQ. She is a specialist of qualitative methods, and her research focuses on the sociocultural field surrounding infectious diseases prevention. She is particularly interested in vaccine hesitancy. De 2012 à 2014, elle était membre de l'Organisation mondiale de la santé, du groupe on vaccine hesitancy. And Dr. Dubé is currently leading the social science and humanity network of the Canadian Immunization and Research Network, funded by Public Health Agency, your agency, I think. Elle va nous entretenir donc de why our First Nation unit getting it before the sick people down south. A look at COVID vaccination in Nunavik. Nunavik, pas Nunavut. C'est ça? Bienvenue. Si on peut rester dans les 20 minutes, s'il vous plaît? Oui. D'accord. Super, merci.
Bonjour tout le monde, ça me fait grand plaisir d'être ici. I prepare my talk in English, but maybe I could do just a show of hands. If you prefer me to present in French, I'm fine in doing both. So who is first language French in the room? Okay, so we're in fact, we're a French university, but as we are a minority, I'll go on and speak in English. So a couple of disclosure, I'm based in Quebec City, so je viens du territoire non cédé des Hurons-Wendat. I have no specific conflict of interest with regard to my presentation today, which has been found by the Canadian Immunization Research Network. I'm coming to present on behalf of a team, some of which are anthropologists that have been working in Nunavik since all their careers. So I do not pretend to be a specialist of Inuit culture, but I did this project in collaboration with some more. So I don't want to bring back traumatic memories by showing this slide. This is a slide coming from another study we did in southern Quebec, where we did weekly survey of Quebecers to look at their perception and behaviors during the pandemic. And in this slide, I show you the answer to the question, the worst of the crisis is behind us, along with the measure that were implemented during the pandemic. So you can see that the perception of optimism varied a lot over the course of the pandemic. In the province of Quebec, we had the most strict measure. We had curfew, lockdown, school closure that were longer and more stringent than in other provinces, yet we did add the highest number of cases as well. So it's just to bring you back in that specific context. And of course, in that context, back in 2020, vaccines were perceived as, with a high optimism, that was the key to the end of the pandemic. And in Quebec, vaccines were promoted with TV publicity, TV ads, media ads, where we saw each other kissing after being vaccinated, and that was like, get your shot, the pandemic will end and we'll get back to normal. Of course, Omicron showed us that we were wrong and that those type of publicity did, I think they were a bit damageable in terms of people's trust in authority and the government. And in fact, most vaccine experts were more cautious about how we should promote vaccination, but still. So there was this high hope, there was a lottery, and we did something as well really particular, that the fact that we had a vaccine passport. So in contrast to Ontario, where some vaccines are mandatory for school attendance, in Quebec, all vaccines are voluntary, but during the pandemic, there was the need to show a vaccine passport to get into some places. So coming closer to the topic of my talk, so this is a map of Nunavik. Nunavik is north the 55 north parallels, and my French is getting at me. The population is around 15,000, and they're living across 14 villages across the two coasts, the Hudson coast and the other coast that I'm blanking the name. And Ungava coast, sorry, thanks, Nicolas. And then I've put some of the measures. The measures that were implemented in Nunavik were not aligned with the measure down south. They were stricter, so they did close all travels north-south, but also inter-community travel right at the beginning, and then they had a curfew earlier than in southern Quebec. But then the measure were lifted as there were almost no cases. And when we look at uptake rate, and I've put the rate at the end of, after 1 year of vaccination campaign, so at the end of 2021, we can see, and this is coming from Quebec Immunization Registry, 2 doses among people 12 years and older. So we can see that Nunavik is the place in Quebec with the lowest vaccine uptake rate, a very important discrepancy when we look at uptake, even though it's not that bad compared to other places in the world. So that brings me to this specific project. This is a project that we started before the pandemic. It was supposed to look at the implementation of a new vaccination program against RSV, but then the pandemic hit and there were no sense to do a project about RSV anymore. So we've decided to work on COVID-19 vaccination instead of. We were supposed to travel to do like classic anthropological field work in the communities. Of course, that was not possible because of the travel bans between the south and the north of Quebec. So because we had some people living in the villages, they helped us recruit, and all interviews were conducted via Zoom or MS Teams. And the data were collected before the vaccination started, so really at the fall of 2020. Quickly, some findings. It is qualitative work, and we did 18 interviews with people living in Inuit from Inuit background, and then also interviews with healthcare provider working in the north, and we also did a social media analysis. Key findings, sorry for the typo, it is especially word without anything after, it should have been removed. So there were high fear of COVID. Even though there were no cases, people were really afraid of this disease, especially because COVID was bad for elderly, and in Inuit culture, elders are highly valued for their knowledge and their strength, so people were really afraid of COVID. But still, despite this fear, it was perceived as something from the South. It was a problem of the South of Quebec. And many of the recommended measures, if you got the cases, were really difficult to apply in the Nunavik context. Quarantines is difficult when you live in crowd household. Regular hand washing was also difficult because there's an issue with tap water in many of the communities, so it was not possible to wash frequently. But at the same time as well, people that had COVID were blamed. There was a high fear of COVID. There were some healthcare provider, because medical travel was still permitted. The nurses coming to work in the north were perceived as bringing the disease. There was some really rude behavior towards those people coming from the south. There was this like intense context of being afraid and discrimination and stigma. And if someone got COVID, there was a few cases, these people were stigmatized in the community. But when the vaccine came, then the fear of the disease transferred to the fear towards the vaccine. Many of the concerns were similar to those we observe in the South. So being concerned because the vaccine was developed too fast. There was vaccine safety concern. Will it cause adverse events? There's lack of studies. And there were also, interestingly, differences in people's attitudes toward vaccination between the different villages. And we saw that there were some community leaders that were overtly opposed to vaccination, and that did influence people's view about the vaccination as well. And what another specific type of concern that we observed in the North were religious concerns. So there were people thinking that COVID was kind of God messages, the apocalypse. So there was all these views around religion that mix into people's view of the vaccine. And for the healthcare provider that we interviewed, that was something specific. They were really like frustrated, if I may say, about these beliefs that they thought were like non-rational refusal of a key intervention because of religious belief. A couple of notes on our analysis of social media discourses. Of course, misinformation is not something specific to Nunavik. It was, during the pandemic, the WHO director said that we were not just fighting a pandemic, we were also fighting an infodemic, an epidemic of information. So we saw a lot of different discourses. Some were not like false at the start. Not all are conspiracy theory. You might recall the front page of The Guardian saying that the vaccine will get us out of the pandemic, that the vaccine is 99% effective. That was real information at the time, but then it was not against transmission, it was not against Omicron, so there was not just, the problem is not just misinformation, myths, and conspiracy theory. The problem is too much information about COVID, about the vaccine, that make people confused. What is the good information? What is the bad information? Those scientists, they don't know what they're doing. They keep changing the information. So that's, I think, was the problem. So we did social media listening down south, looking at all public discourses about the pandemic. And I've put you two graphs from that project with the link to more data if you're interested. But we saw that vaccine dominated online conversations. So of all topics related to the pandemic, most of the conversation were around vaccine, even before vaccine were available. So there were already like all those discourses, and most of the content were negative. So it was not like intense vaccine promotion activities that was done online. The situation is a bit different in Nunavik. So Nunavik, Facebook is used a lot in all villages as a key way of sharing information. So there's radio, the local radio, and Facebook pages. There's often a page by villages, a public page where people go and ask questions, and where you can get health information, but also information about the closure of the tap water and different type of thing. So we did look at 15 public pages. We saw that social media were used a lot during the pandemic to share information about the measure, but also about the vaccine. We saw the same kind of negative discourse that we observe in the South. We saw it as well in our analysis of Nunavik. What's specific, again, is the discourses around religious belief and the interference with vaccination. We saw a lot of distrust as well of, for instance, where the Nunavik Health Board posts information about vaccination or dates or the stuff. We saw a lot of negative comments below the publication. So Nunavik was prioritized. You might remember that at the beginning of the pandemic, there was lack of vaccine supply, so we had limited doses. There was this prioritization of group to receive the vaccine. Nunavik was prioritized because of the issues in applying measure, the remoteness. There's only 2 hospitals and there's limited hospitals. So if people get too sick, they need to travel down south to receive acute care. So for those reasons, the population was prioritized. But of course, that created a lot of skepticism. At the time the vaccination started, we had huge outbreak in the south. Many people died, but there were 14 cases in Nunavik total, and no one died. But still, they were getting the boxes of vaccine first. So they make them like feeling a bit like they were testing the vaccine before we gave it to people down south. So when we look at all those findings, it's easier to say that, oh, we're facing a vaccine hesitancy issue in Nunavik. Are Inuit people more hesitant than people living down south? And this is just to remind that, to me, vaccine hesitancy is the midway between being strongly opposed or highly critical of vaccine and being highly trustful, demanding vaccine. So vaccine hesitancy is kind of ambivalence about vaccine. And we could, when we look at the data that I've showed you, conclude that, yes, Inuit people are more hesitant than people elsewhere, maybe in Quebec. And when we try to understand the factors leading to vaccine hesitancy, there's many models, mostly are derived from social psychology. So this is the most, I think, known model. It's called the 5 C's of vaccination. So it tried to explain why people are hesitant, looking at 5 determinants. So confidence in vaccine safety, confidence in recommendation by healthcare provider, complacency, which reflects to the risk-benefit ratio, so perceiving vaccine are more risky than the disease, constraint to reflect maybe the access to health services barriers. Calculation is developed to reflect the fact that vaccine hesitant people tend to do more research before making a vaccination decision and may encounter more false information about vaccine. And collective responsibility, less true for COVID-19 vaccination, but for many vaccines, when you do get vaccinated yourself, you will protect others in your community through community immunity. And so this is a simple model. This is an old model that I've developed doing a literature review. I don't show you because I think it's good and that you could use it. It's to show the complexity of vaccination decision. I find that different models are looking mostly at individual determinants of behavior, while to have a good understanding of vaccination decision, I think you need to situate those decisions in the larger social, cultural context, the interaction with healthcare provider, what you see in the media, the vaccine politics, economical factors, and those factors are more difficult to assess through survey-based measure. So to help us better understand vaccine decision in Nunavik, we need to understand how health services are provided. So there's a local community center or health center in each villages. Often care is provided by non-Inuit people, so often people on rotation that are coming to do a month of work in the north and then they may never come back. Health services were also highly linked with colonialism. So those services were implemented in a desire to settle Inuit population that were nomadic people into villages. And of course, there's all the past traumatic experience with health services. So at one time there were outbreak, and there still are, outbreak of tuberculosis. But then Inuit people were taken from their family to be treated in sanatorium down south, but they could die there and nobody will ever tell the family about what happened. So that explains, I think, the mistrust that Inuit people may have towards health services. And vaccination programs were implemented at the same time than health services in the 1950s as also as a way to prevent infectious disease. There's a higher burden of most vaccine-preventable diseases in the north. There's specific vaccination programs. So when you look at the vaccination program for most Quebecers, it's different than the vaccination program in the north. But at the same time that we vaccinate, we don't address the underlying causes of these higher burden of infectious diseases, crowd household, issues with tap water, stuff like that. Usually, people were highly acceptant of routine vaccinations, so the coverage was high for most routine vaccination program. But when we dig up a little bit about Inuit views of routine vaccination, there was maybe not always an informed consent. Some parents, for instance, told us that they were vaccinated because they were afraid that otherwise their kids would be taken by youth services protection if they refused to vaccinate. So stuff like that. And most of the diseases most of the outbreaks that occur in the north were brought by people traveling from the south. And this is true as well for COVID. So this perception, of course, borders are less closed now than they used to be in the past, but this perception that diseases are coming from elsewhere is still prevalent. So to conclude, I hope to make a point that there's vaccine hesitancy, definitively in Nunavik, but there's a rational and expected vaccine hesitancy to be the first to receive a vaccine. The fact of being characterized as vulnerable and prioritized for the vaccination is also not aligned with the values of equality and mutuality that are really key in Inuit culture. And it could be experienced as demeaning or infantilizing by Inuit, and that's a discourse that has been received for many, many years. So we need to understand the vaccine refusals in the context of centuries of problematic interaction with the government, with health institutions in the north. So historical, social, cultural, and institutional factors matters when we study vaccine acceptance, and to develop effective intervention to enhance vaccine acceptance and uptake, and ultimately prevent vaccine-preventable diseases. We need as well to work on those bigger determinants of health, not just the individual level knowledge, attitudes, and belief about vaccine. Thank you.
Thanks for your very informative talk. No complex statistic, no p-value to struggle with. The following one certainly has a lot of p-values. Donc, la prochaine présentation va être animée par Madame Noel Tsui on COVID-19 vaccination intention and vaccine hesitancy among citizens of the Métis Nation and in Ontario, Madame Tsui is an epidemiologist at the Institute of Clinical Evaluation Sciences, fully seconded by the Métis Nation of Ontario. Her research interests include infectious diseases, epidemiology, Indigenous health, and health services and evaluation research. So please welcome Miss.
Thank you for the introduction, and hello everyone. It's truly an honor to be here today to share research on the COVID-19 vaccination intention and vaccine hesitancy among the citizens of the Métis Nations of Ontario. So let's dive into the key components of my presentation. We will start with the acknowledgement, followed by exploring what is vaccine hesitancy, its significance in an Indigenous health context, introduction to the Métis and the Métis Nations of Ontario, our research methods, findings, and finally the limitations and future avenues of study. So first, I'd like to acknowledge our funder. So this study was funded by the Public Health Agency of Canada with in-kind funding from the MNO. Also, our partner ICS, which has a data governance and data sharing agreement with the MNO. I'll also like to acknowledge the MNO senators, the MNO leadership and staff members, members of the PCMNO, the MNA, and our academic colleagues that makes this work happen, as well as all the MNO citizens that participated in the study. So what is vaccine hesitancy? It is defined as the delay in acceptance or refusal to vaccinate despite the availability of vaccine services. And this concept challenges the previous held perspective that vaccination attitudes are only a simple dichotomy of accept or reject, but it's far more than that. So as you can see from the graph here, it's a continuum. You get various degree of acceptance and refusal in within. So the current vaccine promotion program uses a knowledge deficit approach where they would assume that vaccine hesitancy is due to inadequate knowledge about vaccines. However, that's not always the case, especially within Indigenous populations. Yes, so there are many factors that contributed to vaccine hesitancy among Indigenous population, such as the long history of unethical medical experiments, cohort sterilization, extractive research, studies, residential school experience, and more. So, for example, during the H1N1 outbreak back in 2009, the federal government sent body bags to 4 Manitoba First Nation communities instead of providing the essential medical supplies and antivirals. And despite Indigenous people having no genetic predispositions or increased risk of severe outcome from H1N1, they were still listed as a standalone category of high-risk individuals, so they're prioritized for the H1N1 vaccines. And this focus solely on indigeneity alone meant that many were left feeling like guinea pigs. And these stories emphasize the need for a different vaccine promotion approach with Indigenous population, as well as a distinction-based approach between nations. So who are the Métis? So the Métis Nation, it's comprised of descendants of people born of relation between First Nation women and European men. The offspring of these unions were of mixed ancestry. So over time, a new Indigenous people called the Métis resulted from the subsequent intermarriage of these individuals. And they have a unique history, culture, and language. This distinct settlements emerged as the outgrowth of the fur trade, along with freighting waterways and watershed. However, it's important to note that the ethnogenesis of distinct Métis communities along the waterways and around the Great Lake regions of present Ontario occur as these new people were no longer seen as extension of their maternal, which is the First Nations, or paternal, which is the Europeans' relations, and begin to identify as a separate group. And the Métis Nations of Ontario was established in 1993 through the will of Métis people and Métis communities throughout Ontario coming together to create a Métis-specific governance structure. And the Métis Nations of Ontario was not created to represent all individuals and community that claim to be Métis, but those that are part of the Métis Nations. And if you would like to know more about the MNO, their statement of prime purpose can be found on their website. So the MNO currently holds a registry of over 28,000 Métis citizens and approximately 30 chartered community council across the province. It has established a accountable, result-based provincial delivery structure to meet the socio-economic needs of its citizens and community. So currently, the MNO delivered programs and services to its citizens related to healing and wellness, housing and infrastructure, education and training, and more. So this study was led by the MNO. So we use census sampling, and we sent out email invites to all citizens that have a valid email on file at that time. And we have 4,470 citizens completed the survey between February 8 to March 8, 2021. So that's incorrect. That should be corrected, but it's done in 2021. And we measure vaccination intention and the 5C psychological antecedents of vaccination. So the 5C, just like Dr. Dubé just said, they included confidence, complacency, constraint, calculation, and collective responsibility. So confidence was measured through the respondents' confidence towards the effectiveness and safety of the COVID-19 vaccine. Complacency was measured through the respondents' perceived risk of contracting COVID and the severity of the disease. Constraint was measured through the respondents' willingness to receive the vaccine despite barriers. Calculation was measured through the respondents' engagement in researching and weighing the pros and cons of receiving the vaccine. And lastly, collective responsibility was measured through the respondents' belief as to whether everyone should be vaccinated to protect each other and prevent the spread of COVID-19. And we use a shorter form of the 5Cs, where we only included 1 to 2 items per antecedent in our survey. And for analysis, we use descriptive statistic, bivariate analysis, and multinomial logistic regression to analyze the survey data. Okay. So vaccine intention was measured with 1 question. So respondents were asked to indicate their agreement or disagreement with the statement, "I plan to be vaccinated," with response options ranging from strongly agree to strongly disagree. So based on their response, we categorized the respondents into 3 groups: the intenders, which were responding with a strongly agree or agree response; the unsures, which were respondents with an unsure response; and the non-intenders, which were respondents with a strongly disagree and disagree response. And as you can see on the pie chart, the majority of the respondents fall into the intender category, which is a positive outcome. And here's a bar chart to compare the vaccine intention within MNO citizens and other indigenous group and the Canadian population. So as you can see, 70% of respondents expressed high intention to receive the vaccines as they were being released to the public. This aligns with a report from Statistic Canada on vaccine hesitancy, where 68% of self-identified Métis also reported a willingness to receive the vaccine. And in comparison to other Indigenous population in Canada, our vaccine intention rate is slightly higher than studies that included a pan-Indigenous group, which included the First Nation, Métis, and Inuit. Specifically, 65% of self-identified Indigenous respondents intended to receive the vaccine. And when compared to the Canadian population, our estimates were on par with their high level of vaccine intention. And here's the table comparing the intender group, unsure group, and non-intender group with the 5C. So the percentage indicate the proportion of each group that agrees with the statement except for constraint, which is flipped. So for confidence, 95% of intender, 5% of unsure, and 0% of non-intender agrees that they are confident that the vaccine is safe. And for complacency, 80% of intenders, 16% of unsure, and 4% of non-intender agree that the COVID-19 is severe. In terms of constraint, 80% of intender, 12% of unsure, and 8% of non-intender disagree that everyday stress will prevent them from getting the vaccines. For calculation, 70% of intenders, 19% of unsure, and 9% of non-intender agree that they will weigh the risks and benefits to make the best informed decision. And lastly, for collective responsibility, 82% of intender, 14% of unsure, and 4% of non-intender agrees that vaccination is a collective action to protect others. Okay, and now we'll have a look at the odds ratio. So here's a chart comparing the odds of agreeing or disagreeing with the 5C statements between the intender group and the unsure group. So the intenders were significantly more likely to have confidence in COVID vaccines. Complacency was also higher among intenders, as they tend to believe that COVID-19 is a severe disease. And interestingly, there's no difference between the intender and the unsure in terms of calculation, meaning that both groups weigh the pros and cons to make the best informed decision. And intenders were also more likely to agree that it's a collective action to prevent the spread of COVID-19. And lastly, constraints were lower among intenders, suggesting that they don't believe that everyday stress will prevent them from getting the vaccine. So now move on to the comparison between intenders and the non-intenders, which is also quite similar to my previous graph. So the intenders were significantly more likely to have confidence in the vaccine and think that the COVID-19 is a severe disease. They were also more likely to agree that it's a collective action to prevent the spread of COVID-19 and exhibit low constraint, indicating that everyday stress wouldn't deter them from getting the vaccine. However, intenders were slightly more likely to do more research and weighing the risks and benefits of getting the vaccine compared to non-intenders. Okay, so now because we're in 2024, I do have some actual vaccine uptake data that I'd like to share and compare with other population. So it's important to note that the information on the relative importance of the 5Cs in MNO citizens were used by the MNO in real time to guide information sharing and educational activities tailored to their citizens during the vaccine rollout, which enable Métis specific health promotion messaging. And as you can see here, as of August 2021, 80% of MNO citizens have received at least one dose of COVID vaccine, with 74% having received 2 doses. And these figures are higher than our results collected from the survey, which is great. And in a Canada-wide survey, 87% of self-identified Métis reported receiving at least 1 dose as of February 2022. And when comparing to other Indigenous population, a study that looked at COVID vaccine uptake among Indigenous group living in Toronto reported 58% having received 2 doses as of December 2021. And in comparison with the Ontario and Canadian population, the vaccine uptake rates among MNO citizens are much higher. And these accomplishments should be viewed through a strength-based lens, and the MNO's community commitment to health and resilience should be emphasized. So while our study offers valuable insights, it's not without limitation. So the first one being that we only capture MNO citizens that have a valid email on file in January 2021, which excluded citizens that don't have an email or have internet access, and also Métis people that are not registered with the MNO at that time. And the second one being that the data collection period was during a provincial lockdown and Ontario's phase 1 of vaccine rollout, where only high-risk population were eligible to receive the vaccines. So booking for the vaccines were just opening to adults over the age of 80 on March 1st. So only a very small portion of the population would have actually received the vaccine during data collection. And the intention and the 5C may be different if the survey was deployed during a later stage of vaccine rollout or not during a lockdown. And moving forward, we'd like to dive deeper into the relationship between the 5C and the actual COVID vaccine uptake among citizens, and also the uptake of other vaccine. So in conclusion, 70% of Métis citizens expressed an intention to receive the COVID vaccines, and among them, there was a high level of confidence, complacency, and collective responsibility. These findings were valuable in assisting the MNO in real-time information sharing and vaccine promotion campaign tailored to MNO citizens during the COVID vaccine rollout. So while the high vaccine uptake rate among MNO citizens may or may not be directly attributed to these efforts, acknowledging the legacy of colonialism, practicing culturally safety, and tailoring health promotion message to specific nations are crucial steps towards progressing vaccine promotion among Indigenous population. And thank you all for listening.
So the last talk of this panel will be given by Dr. Peter Newman on vaccine hesitancy versus vaccine hunting, multi-level influences on COVID-19 vaccination among racialized community in North America. So Dr. Newman is a full professor of the University of Toronto, and he was a holder of Canada Research Chair on Health and Social Justice from 2007 to 2018. He is an inaugural fellow of the Society for Social Work and Research, and Dr. Newman research address global health and human rights with a focus on HIV and social health among sexual and gender minorities. So welcome, Dr. Newman.
I really want to thank the Interdisciplinary Center for Black Health for inviting me here, and I'm very pleased to be here and also to hear, access to some of these other really interesting talks. It's also a little different sometimes when you're giving a talk. It's usually the people who are sometimes cited in your talk, they're far away across the country, across the world. I have a couple, a few folks here, plus the kind of real world data from Health Canada and PHAC's analysis. So, feel free to intervene or correct. It'll hold me accountable to what I say. So I'm not going to present probably all of what I have here, but mostly what I'm going to present is we did a scoping review, which is a kind of systematic review, but it takes into account qualitative and quantitative and mixed methods research. And we did it for the first year of the availability of vaccination. And we looked at all publications within that time. And I would just say for anyone who's either pre-tenured or doing research as a doctoral student, don't try this, because the research kept coming out so quickly that we had to keep kind of delaying, and you can't send it to a journal over a year after you finish the data analysis because it's not current. So man, that was tough. It's kind of like a rat on a wheel. So, just by way of introduction, I think I won't repeat this, but in terms of data globally, vaccination is estimated to have prevented, a tremendous amount of disease and mortality. And it's often a challenge in any type of prevention research, and this is not limited to COVID, that it's really hard to know how bad it would have been if you didn't have the intervention. And that's in any field, and it's certainly in what I've been doing mostly for the past couple of decades in HIV research. So this is a public health researcher in the United States, because early on, and when we looked at the scoping review, it's highly influenced because it's from the US and Canada. There were a lot of studies from the United States early on. And there were claims in the US, despite Trump and all that, oh, we're all in this together. I mean, obviously anyone can get COVID. It's not like a disease that's related to any kind of genetic differences or et cetera. But she put it quite succinctly in actually a really amazing short piece. You know, by no means, we are not all in this together. And there's a good deal of data that supports that, which I won't go into. One of the main issues is, to the extent, like so from social work as other social sciences, we look at social determinants of health. The same social determinants of health that rendered various communities at higher risk, more likely to contract, to be face COVID, to be infected, and to have worse outcomes, those same disparities in terms of social determinants of health also impact access to vaccines and to healthcare more broadly. So this is not for me, but I thought it was a really interesting and thoughtful approach to think of this notion of an inverse equity hypothesis. So that basically that new interventions in anything, and again in my line of work in HIV, they're often not first available to the people who are at greatest risk. They're available to people who are the most socially connected, who have the most money and access to the system to get those. One reason why this is important is because sometimes, I certainly know from the US CDC, there were good attempts, and many in Canada too, to reach out to certain communities to increase rates of vaccination when we knew there were disparities. And there's a tendency to think, okay, so now we've leveled the field. Great. The trouble is that it happens, and I think your data from Health Canada shows us that it can happen again and again. And so it's so great to have longitudinal data to see that when boosters were first available, it was also then not the people who were at greatest risk because of adverse social determinants of health. It was people who were more socially connected, had more money, had more access to power, who had greater access. And so that actually, for quite some time, when a new intervention comes out or a new vaccine, it actually amplifies the disparities rather than leveling them. So several of the speakers have talked about this as I anticipated. I won't go into this, but I'm just going to tell you that my work is focused on, despite it's being readily available. It's that part of the vaccine hesitancy definition. And so this is characterizing, and I'll show you, but like over 100 studies, largely from the US and from Canada, a smaller proportion, looking at, in the first year, so what did people write? Like, we searched any article that talked about vaccine COVID and vaccine hesitancy, vaccine trust, vaccine confidence, vaccine refusal. In fact, it really is true, Professor Sanaa, your study is one of a few from Canada that even, was there. And it's also one of the few that took a critical approach, because a lot of studies, and I know people, they're trying their best, they're trying to do good work and explain what are these disparities, but a lot of researchers just use this term and do interesting work, but don't think about the other part of it, which is despite it's being readily available. That is a monstrously huge supposition in North America and in many places around the world. Huge. I mean, if we really look at that, that is a leap of faith that, is way far out there. So I think I'm going to talk mostly about this scoping review. we did do a qualitative study in the Greater Toronto area as well. So this is the scoping review, which was really a labor of love and craziness. And I want to acknowledge my collaborators. So this study particularly was funded by CAHR, and my collaborators, Charmaine Williams and Notisha Masakoi, had a lot of input into this, and then several postdocs from U of T, Kate Allen, Tabani Nyani, and Sophia Fantas, and my really great research assistant, were very, very helpful. So I won't talk too much about this. You can ask questions if you want, but it just says the date. So we started from the beginning of 2020 onwards out to, in terms of publications, to the 25th of October of 2022. So whenever you do any kind of overall review like this, you want to try to have a kind of fairly transparent, crystal clear question to the extent that's possible in social sciences. So what are the determinants of vaccine hesitancy in the context of COVID-19 vaccination of marginalized populations in the US and Canada? So we can talk about that, but as we did the work and published it, we had to define what we meant by marginalization, and basically sort of being removed from access to economic, political, and social power, and in terms of racialized populations, often driven by ideologies of racism and other structural stigma. So we wanted to look at, so in this period of research, what were the focal populations among these groups among whom vaccine hesitancy was researched? And then, what are some of the determinants? And we also used this social ecological model as Professor Dubé has talked about, and also very helpfully used it in some studies of vaccine hesitancy among parents and their children years ago. So it kind of helped us to gain some traction to say, we're not just making this stuff up, someone's actually done this. So this is too much information, but it's just to show how many thousands of articles we had to review. And a lot of them, thankfully, were duplicates, but still from there, then you chart, well, how did we got even getting to 500 full texts is like crazy to do in a review. Some reviews, if you have 10 to 20 or 30 articles, you have your work cut out. So, I mean, we had a team of 8 people doing this. And even when we culled it down, because we had to then look at those full texts and say which ones make it in, which ones don't, it was over 100. So just here's some results. I'm certainly not going to present everything, but that gives you a picture. So across these 100+ articles, it was over 440,000 people, but the studies range very, very widely, which is what you can do in a scoping review, from, qualitative studies of n equals 10 to then huge population-based surveys. And a population-based survey only got into our review if, by definition, more than 50% of the sample were among marginalized populations, particularly racialized populations, or else it's out. And also, if it was population-based survey, it had to disaggregate the data, like this data we've been nicely presented, to say what are some of the differences. This is just a view, as one would expect, over time. And just, for me, I just think of the agita of these constant stream of articles coming out. So we looked then across these 100 articles, and it's somewhat of an inductive process, but it keeps us honest that we publish a protocol first and say, hey, here's what we're going to look for, and also there's a theoretical model behind it, the social ecological model, which has a lot of support. But then we still had to kind of inductively look at what we're calling structural, social, individual, and vaccine-specific determinants, which I'll show you. I don't know how easy this is to see. It wasn't easy to make. but so then this is across all 100 articles. among all the factors we discerned, what was most prevalent. So quite honestly, there's some subjectivity involved in this, as well as there is in all research, but far and away, across these 100 articles, now it's focused on marginalized populations. It's important to realize that it's not just looking at the whole population. As you see, that top factor, which I can't even see the name of. Hey, does someone mind reading the top factor?
Structural systemic racism, stigma, and external disruption.
So that was, thank you very much. That was the most prevalent factor across these 100 articles. And, you know, we didn't ignore what you would also think. I mean, still, of course, there were these concerns about side effects. The vaccine came too early. I mean, these kind of more vaccine-specific issues and things that are more individual level were there. So you can just get a sense of the, what color do you call that? Like magenta colored, that top line, and you can look down to some of the other things that we're calling calling structural factors. And I'll talk about a few of them. So when we parse this out by the 14 different marginalized groups that we covered, so it was racialized populations, but it was also other groups, people with disabilities, people who use drugs, people living with HIV, etc. People experiencing homelessness. So it was not just about racialization, but still by far and away, the most articles were about African American and Black Canadians, Black people in North America by far. And if you look at that, a very, very high proportion of the articles that address that Black populations talk about structural barriers. Almost all of them have something in there. We also did things like, so this is based on looking at focal populations, but we also took into account research which, for example, which included multiple populations, so it wasn't focused on Asian people. There were actually no articles in that time period that focused on Asian people. There was little or none on, broadly speaking, Indigenous peoples. And so some of that data came from taking the data out of these large studies and looking at it. And so indeed, that was helpful. So that, as I said, so, I mean, we can't really compare it, but like even when we're looking at, I mean, given the focus of this seminar, also in terms of American Indian, Native Hawaiian, Indigenous peoples, there were few articles, but you know, in those articles, the structural factors were also quite present. These are just some quotations and a little bit of thoughts on some of what those are. One of the differences is a lot of articles that dealt with COVID vaccine hesitancy among Black and African populations in North America did mention mistrust, but more of them talked about mistrust as a historical thing. In the past, this is what happened. This is what medical racism looks like in terms of experimentation on Black bodies without consent. Much less of them talked about the fact that there's racism in healthcare, like right now also. It just, perhaps it wasn't their focus, but so just to say that. So I just want to get across that point because I think it's important. And the other thing is that a lot of studies, in the same way that they use the word vaccine hesitancy to just cover the whole playing field of the difference between people who are vaccinated and not all studies did that, but a lot did it. They attributed all the disparity to, quote, vaccine hesitancy. Many of them without defining what that means. It's a concept that was extraordinarily helpful and even prophetic at the time it was introduced, but it may be going out of control in terms of how it's being applied. I mean, that's not to, you know, put anything on folks who are doing honest, good work within and looking at spectrums and the like, but often it's applied in this way. You can't always control the outcomes of what you do. So many articles didn't really discuss very much. They maybe mentioned Tuskegee. This is in the United States. That's like code word for not really wanting to talk too much necessarily about medical racism, but okay, we all know what that means. But they looked at it, and this is something that evolved, frankly, in our looking at these articles was, and people may agree or disagree, that it came apparent to us that institutional mistrust born of medical racism is not an individual level factor. Going around and interviewing and talking to individual people, that is important because there's still vaccine hesitancy too. But if you really want to look at it at this level, we have to peg that as a structural factor. So, and this, I mean, people here may have more on this. The articles were actually contradictory around this in terms of, would a provider of your own race, ethnicity, would you believe them more? Some people, yes, but I know from our qualitative study, we had some folks, and I remember a very strong quotation from a black woman talking about feeling infantilized by someone saying that. Oh, if only a black doctor would say it, then you would, She said, no, I'm not getting this. And she had reasons for not doing it. So that has to be thoughtfully applied. And so in many populations, even so-called marginalized populations, there are also strengths that come out in terms of who might be the representatives in a community that people would believe that would be good messengers. As came out before, it was 100 studies, but very few focused on Indigenous populations, the notion of concern for older people. And there was a different flavor, if I could say, among predominantly Black and in the US, certainly also Latin populations. There's just a frank mistrust based on historical mistreatment. There was an added thing in terms of these populations that it wasn't even first about mistrust, it was about autonomy. It's do not tell me what to do. Do not come here and tell me how you should do it. And it was at least equally as high as the mistrust issue. So that's something that could be looked into as well. This is also we looked at intersectionality in terms of, you can see this quote from trans people because they're local places where they felt comfortable getting healthcare. And this is true for racialized populations too, were largely closed down. There were these mass vaccination clinics in Ontario and in Greater Toronto area for sure, and sometimes people felt very uncomfortable going there because it wasn't their usual source of care. So this is about access, and I'll have to skip this. We did a little bit, I don't have much that I'm going to put here, but obviously intersections, as someone here talked about, the intersection between immigration and racialization, right? That's clear and important. And also, again, some strengths that are born of that. So we found broad evidence for multi-level determinants of COVID-19 vaccine hesitancy, a preponderance of structural level barriers due to medical mistrust, both historical and present day, and barriers in access. And this is like lack of access to transportation, lack of familiarity with how to use digital media and the internet, lack of information in your language. In Toronto, the Greater Toronto area, I believe there's about 42% of people whose primary language is not English or French, right? So that they didn't have access in their own language and their mother tongue to information. And then also cultural tailoring of how you present the information. These are all in this realm of what we're calling structural. So there are different levels within structural. And so the main point I really want to get across is, while I do believe there's certainly vaccine hesitancy among these marginalized populations, there are differences within the populations for sure, tagging that and focusing on that, vaccine hesitancy, that's what's going on. It's actually not necessarily intentional, but it is an instrument of racialization. You are taking a structural issue and you are foisting it on individuals and then naming it like that, so that it's like a double, triple whammy in terms of, it's avoiding the structural issues, and then it's blaming communities and individuals for their low uptake, which may not be what's intended, but this is what emerges and what some of the folks that we interviewed too in our study talked about. And so just in the big picture, it's really important to address vaccine hesitancy, but if that's the focus of efforts to increase COVID-19 vaccination and reduce disparities in other kinds of vaccination and access to health care, I'm not, a seer, but it's not going to work because you're missing a huge part of the challenge. And interventions are very hard. I certainly don't have the answers of how do you address that, how do you deal with that. But it actually does more harm in some ways because you're foisting it. And so I think that one other takeaway from the scoping review is vaccine hesitancy is not only a characteristic of Black people, and it's not only a characteristic of Indigenous First Nations people, that it exists across, but that a large part of what we see in terms of the disparities, from my understanding, is due to structural factors and barriers in access, not to psychological issues and psychological constructs that are sometimes predominantly what we look at and measure. So we'll get to that another day. Thank you so much for your attention, and it's really been a pleasure to be here.
So before opening the floor, please, I think our two speakers deserve a big applause. La session des questions ouvertes. Maybe a warm-up question to Dr. Newman. Why running? Okay. Let's ask my question and working. Why you run a scoping review instead of a systematic review?
Thank you for the question. See, I even tried to avoid the methods and you didn't let me. But particularly because we were interested in particularly marginalized populations who, if we only looked at systematic reviews that had sufficient data to disaggregate populations, we would miss. We would say, oh, we don't have enough samples, there's not enough sample size. It's not most of the surveys are not Health Canada surveys, right? They're researchers doing their thing. Some of them higher funding. And so we really wanted to make sure to allow in qualitative research, which sometimes in companionship with quantitative research can deal with some of the potential insights, things, if you're very quantitative minded, one could think things you might measure later, but things that even a well thought out survey, if you didn't ask it, you're not getting an answer. And we didn't know what all the issues were, so thanks for the question.
My question is for Dr. Dubé. You noted the role of scientific. Vous l'avez vraiment noté très subtilement, puis j'aimerais vraiment revenir là-dessus. Au début de la pandémie, les scientifiques ont été, et surtout au moment encore plus au moment de la vaccination, étaient partout pour parler. Beaucoup de fois, on n'a pas dit qu'on ne savait pas. Et j'aimerais savoir justement le rôle qu'on a pu avoir, et surtout même au début de la pandémie, à chaque fois qu'on parlait, que les scientifiques parlaient, on ne disait pas qu'on ne savait pas. On disait des choses. Une semaine après, il y avait des choses qui étaient changées. Les mêmes revenaient à la télévision et à la radio pour dire d'autres choses. Et à chaque fois, on revenait pour dire d'autres choses. Puis à un moment aussi, je questionne notre rôle dans ce qui s'est passé au fait après pour la vaccination, quand les gens se sont mis à dire ils ont changé puis là je parle de personnes très logiques qui ont dit ils ont changé à chaque fois d'opinion en nous disant c'était la bonne chose et tout. Puis moi je me souviens très clairement au tout début de la pandémie, il y a un ensemble on a organisé, il y avait quelque chose qui était organisé par le Social Organization Science Group de l'OMS. Puis on vient de déclarer la pandémie. Puis et là tout le monde commence à dire mais de toutes les manières nous ne pourrons jamais faire comme les Chinois, on ne fermera pas. C'est impossible. Et il y a un collègue européen, quand il l'a dit, j'ai posé une question pour dire, moi, je ne serais pas très aussi dur, aussi... Puis là, c'est quelqu'un avec qui j'ai travaillé par le passé. Il m'a pris, mais comment on est en démocratie, on ne pourra jamais faire ça, il faut trouver d'autres solutions. 2 semaines plus tard, on a tout fermé. Et c'est quelqu'un qui est parti dans les médias beaucoup de fois en France pour dire on ne fermera pas tout, mais il avait des solutions. Puis je me demande quel est le rôle qu'on a eu, le fait qu'on a tellement changé d'opinion à chaque fois, puis à un moment que la population puisse ne pas trop croire que, parce qu'on dit que la vaccination c'est une bonne chose, que c'est une bonne chose. So I want to question our role on that.
C'est un excellent exemple. Au Québec, on a eu l'histoire des masques. On manquait de masques, donc les masques ne sont pas nécessaires, ne sont pas utiles. Bon, ne portez pas de masque, et puis tout d'un coup, le masque est obligatoire partout. Oui, et tu sais, bon, il y a des... C'est effectivement un problème. On associe beaucoup la désinformation à la théorie du complot, la religion, alors que la communication scientifique, ce n'est pas donné à tous. La nuance, c'est pas très super quand on parle à des journalistes non plus. Tu sais, ils sont à la recherche de la minute pour mettre dans le bulletin télévisé. Puis, je parlais à un journaliste, je lui demandais, qu'est-ce qui fait un bon expert? C'est quoi un bon expert que vous allez interviewer sur une question? Il dit, un bon expert, c'est un expert qui répond à ses courriels. Donc, someone who wants to be in the media could speak on every topic he wants to if he get it. So I think there's definitely a role of that. And, you know, in science, we know that science is working. There's no truth. We keep working towards truth, but there's no truth, and science is evolving. I don't think people get it in the public. So there's ways of communicating uncertainties that we should be better at, and we should not spoke on topic that we are not expert of as scientists. I think that's our responsibility, and we should be clear with journalists as well when we speak, which is not given to everyone.
Bonsoir tout le monde. En fait, ma question c'est pour le docteur Dubé. Je pense que quelque part dans votre exposé, vous aviez dit que au Nunavik, les gens ont eu peur de la vaccination au lieu, c'est-à-dire par rapport à d'autres maladies comme ça. Mais croyez-vous, est-ce que vous ne pensez pas que c'est à cause de la rapidité, avec cette rapidité que la vaccination a été... on a produit les vaccins, parce que si nous prenons comme exemple des infections, par exemple, VIH, par exemple, aujourd'hui encore, on en parle, il n'y a pas de vaccin, mais maintenant, avec la COVID, et puis il y avait une rapidité, et puis c'est fait. Mais on se pose des questions. Croyez-vous que c'est à cause de cette rapidité qu'on a fait, on a produit les vaccins qui fait qu'il y avait cette peur bleue parmi les gens?
C'est définitivement un facteur qui a joué. Effectivement, les vaccins ont été produits rapidement. C'est quand même une nouvelle technologie, donc c'est sûr que ça a facilité ce développement rapide-là. Et le fait qu'avec la pandémie, la fermeture de tous les scientifiques se sont mis à travailler sur ce virus-là en particulier. La technologie va ouvrir la porte à de nombreux nouveaux vaccins. On en voit aussi beaucoup. Fait que c'est une question à laquelle on va être confronté de plus en plus souvent, mais c'est tout à fait normal. Puis, on parlait de discours dans les médias, de discours scientifiques. Au début, on disait que c'était impossible d'avoir un vaccin alors qu'on l'a eu. Fait que ça aussi, quand on parle de confiance, puis effectivement, on n'a pas d'études, on n'avait pas d'études à long terme. Cela dit, il y a une portion aussi de représentation. Moi, je travaille beaucoup sur le vaccin contre le VPH. C'est un vaccin qu'on utilise depuis 2008, mais il est encore perçu comme un nouveau vaccin, puis les gens ont encore peur de ce vaccin-là parce qu'ils trouvent qu'il est trop nouveau. Donc, il y a cette portion-là qui n'est pas nécessairement aussi toujours rationnelle.
OK, ma question, c'est par rapport aux différents types de vaccins. Donc, je sais qu'il y a des gens qui avaient comme des préférences. Donc, moi, je veux Pfizer, pas Moderna, etc., etc. C'est sûr que ça peut être lié, on va dire, à leur effet indésirable. Mais ce que moi, je veux savoir, imaginez qu'on avait juste Pfizer, on va dire un seul type de vaccin. Donc, pensez-vous que ça aurait pu, en quelque sorte, améliorer la couverture vaccinale?
C'est quand même surprenant. On a eu au Québec, tu sais, le vaccin AstraZeneca, qui est une autre marque, qui est un vaccin avec sur une autre plateforme et qui a fait quand même, tu sais, qu'il y a des effets secondaires avérés, les thrombocytopénies, et il y a eu des décès qui ont été liés à la vaccination. Malgré tout, les gens ont continué de vouloir le vaccin. Donc, oui et non. C'est certainement quelque chose qu'on devra mieux étudier dans le futur parce qu'on a toujours eu plusieurs sortes de vaccins. Tu sais, on a plein de vaccins contre la grippe. Jamais personne disait, ben là, j'ai-tu Pfizer ou j'ai-tu celui de Merck, là, cette année? Ah non, je veux pas. Mais il y a eu quelque chose et il y a eu un effort. Tu sais, il y avait des Pfizer Group, on regardait sur les médias sociaux, les gens, tu sais, se posaient puis ils mettaient la marque de vaccin. Il y a quelque chose dans le marketing aussi qui est particulier, qui a changé avec la pandémie et ça l'a mis les gens beaucoup, beaucoup plus à l'affût de toutes ces questions-là, de où est fabriqué le vaccin, c'est quoi la marque. Donc, c'est des questions qu'on voyait pas et que en tout cas, quand on parle à des infirmières, des médecins, des fois, sont un peu surpris avec ce genre de questions-là très pointues qu'ils ne recevaient pas avant la pandémie. On est, tu sais, quand on parlait tantôt d'équité, on est quand même chanceux d'avoir eu des doses de vaccins en masse au Canada pour pouvoir se faire vacciner rapidement.
Thanks. Also, I think it's interesting that, so far as I'm aware, actually it's 40 years of HIV vaccine research that propelled us into mRNA, and that's part of why it came out rather rapidly. On the other side of it, we're still 40 years into it as HIV more and more infects and affects marginalized populations with no vaccine. Just the other piece, which I think I forgot, but what we didn't learn, though, unfortunately, and there's stuff written about this from the HIV epidemic, was how to deal with the social issues, and that's the structural issues, and you know, I think, you know, there's this high respect, and it's important, like, you know, high science and bench science and the like. It's much more messy to do social science research, and then the whole thing of how do you implement the findings. So that's stark lessons from HIV.
J'aimerais juste faire un petit commentaire sur la question de la comparaison avec le VIH parce que je pense pas en avoir besoin parce que ça c'est quelque chose qui s'est retrouvé dans les médias sociaux et l'explication est très simple. Un vaccin, depuis le tout premier vaccin contre la variole, un vaccin reproduit d'une certaine manière l'immunité causée par l'infection. Donc, on essayait de faire et le VIH l'infection au VIH ne produit pas d'immunité. Donc, c'est pour cette raison très simple qu'on n'a pas encore de vaccin contre le VIH. Les gens qui attrapent le VIH ne développent jamais une immunité qui leur permet de débarrasser l'organisme de l'infection, alors que la COVID, comme à peu près toutes les infections pour lesquelles on a des vaccins, ben on ne fait qu'imiter l'infection naturelle sans le risque de l'infection. Donc il y a je voulais juste mettre cette mise au point. Il y a une explication scientifique à la différence entre les deux.
I have a question. Can I? Oh, sorry.
Go ahead.
Yeah, my question is, what will you do differently now? For example, if we have a new pandemic now in Nunavik, in Métis, and what will you do differently to increase the rate of vaccination in, I would say, ethnically diverse populations? What you will do differently? What will you propose?
The mic is open.
For three of them.
I'll go first and then you go. So I do strongly hope that we won't be facing a new pandemic in the coming months, because I do think it will be harder to mobilize people to get vaccinated. I think we did some great work during the pandemic in building trust and relationship with different group, community leader. I do strongly believe in this, working at the local level on tailoring intervention to fit with different people. I think too often in public health, we do like mass center, mass campaign, so I do think we need the tailoring. I hope that the relationship that were built throughout the pandemic will continue, so that we are able to mobilize those groups to address some of the more structural long-term barriers and increase equity in health at the end.
Thank you. So as for the Métis Nations of Ontario, I think what we did before was okay due to the high vaccine uptake rate. But I think if we were to have another pandemic, I think having a specific clinic that's like a vaccine clinic by the MNO would be helpful for the Métis citizens, because we did heard from some participants that they were questioned at their local public health center when it was when the vaccine was prioritized for Indigenous people. So they were able to go in there to get the vaccine, but they were questioned that if they were actually Indigenous. So, and then between the current tension between First Nation and Métis, some didn't really feel safe going into a space like that. So I think having like a Métis specific vaccine clinic would have helped if we have something like that in the future. Thank you.
You want to add something?
Yeah, I mean, certainly both of what you said, I think, gets to the core of it. So just some other issues that I think in Canada, we think that, well, they're free. There's free access to healthcare, and that to realize the indirect costs that people in our qualitative study talked about. I have 2 sick days. I have to wait in line for 7 hours at a mass clinic to get a vaccine. What if I have some kind of negative effects? I have children to take care of. So realizing some people couldn't literally afford transportation because vaccines were systematically less available in some racialized neighborhoods in the Greater Toronto Area. So you had to travel to get the vaccine, more so than people there. And literally it's free, but I have to lose a day's pay of work. So that these look like small things in terms of like conspiracy theories are much more electric but that those also create barriers in access. But that idea of, I think, and it's been even in some of the medical literature, trying to localize access. I mean, of course it's hard. And so in addition to the mass vaccine clinics, because it's also the familiarity and someone you trust in it. It doesn't have to be the same healthcare provider, but just a clinic that you've been to before can make a big difference in someone's also not being talked down to when they have questions and being spoken to with respect about what their concerns are. So.
Question suivante.
Hi. My name is Kate. I work with the OAC, so the Ottawa Aboriginal Coalition. And we actually, my colleague Kyra and I, we are the researchers for our COVID study, and part of it was looking at vaccine uptake in Ottawa. And so our community, our urban Indigenous community, had 72% uptake. And it's like one of the highest in Ontario, I believe. And that was largely attributed to like our partnerships and relationships that we had, both with OPH as well as other hospitals and institutions, and just like really good working relationships and OPH's willingness to talk with our elders, and then talk with our OAC organizations. So we have 10 organizations in our community here. And just to like build on what some of what you were just saying is that I believe there's 3 there's 3 organized medical Indigenous clinics that our community members could go to, and that was really helpful for them. I know that like a lot of what we focused on was relationship and like building that relationship and then helping our community. Barriers were a big part of it, but I was curious to know if like the MNO, like how they built relationship, because yours was like provincial wise, ours was very localized, and we really emphasized like the relationship in our community. But yeah.
Thank you. Yeah, that's a great question. So for the MNO, we do have like their local council. And then I think during the COVID, we actually have like a hotline for people that they could call in, and then we'll have someone to help them to find like their nearest clinic and like what they have to bring to the clinic, and like they guide them through the whole process. So I think that's a very major point of building relationship with like the local communities and like promoting vaccine uptake. Hope that answered your question.
Schwab, tu peux déclencher ta question?
Basically, I just have a little comment and a quick question. We talked about vaccine a lot. It's good. The vaccine saves lives. But there's a group that I don't hear much of: school children. They suffer the most. Their support system was shut down for 2 years, which was a devastating blow to a lot of them, and a lot of them were abandoned to their abusers during that time. We know, because now information is coming out, that they suffered and will suffer more from the mismanagement of COVID rather than from COVID itself in the years to come. So how do we go about convincing or educating the younger generation so that we can avoid a massive scale hesitancy among that population in the near future? Because soon they'll be adults, and there's conspiracy theories that's just very prevalent with that particular population. And what is being done currently to reach to them and educate them about the importance of the vaccine, and also to apologize to them somehow of not having done enough to protect them during the pandemic?
Who will try?
You're right. And at the beginning, we didn't know, and most infectious disease like EOUT are highly spreaders of virus. So I think it makes sense at one point to close school, but at some point the negative consequences were higher than what we wanted to prevent, but the government stick with the measure. It's interesting what you're mentioning, because in my other work where we're doing lots of survey, I see a huge generation gap in terms of trust in vaccine. When we looked at 35 years and younger, the level of trust is much lower. So there's definitely something there that we need to better understand. I don't know exactly why, but those are the parents or the future parents. So we do need to do some work. And I know there's some initiative like Kids Boost Immunity in BC that are trying to promote vaccine. I do think that, public health is a lot working in silo. I think we need to promote different things: science literacy, media literacy, health, not just vaccine specific stuff, although I love vaccine, but you know, make it larger, I guess.
I just have a small answer, which is that one aspect of what we learn in looking at different communities and populations and talking about tailoring the response is young people are also a really important population in of themselves. And we know from the HIV epidemic, there's a lot of challenges, additional challenges, when young people of any race, ethnicity, disability status, etc., have to face a healthcare system that's designed for adults. And even for adults, it's a damn hard nut to crack sometimes. So that doing community engaged research with young people and really listening to young people in terms of what to ask and how do you interpret certain things is one, you know, it's just one pathway forward.
Hi, I'm Natalie Holmes from the Public Health Agency of Canada, and this is not my area, but I was part of reviewing proposals. So there is something called the Immunization Partnership Fund, which just closed an open solicitation, and it's specifically focused on healthcare workers, underserved or equity-seeking populations for different types of interventions focused on the types of issues that you're talking about. So young people, children, could potentially be healthcare workers as well, being to gather information to see if interventions work. So we are looking at it. I do not speak for the Public Health Agency of Canada. I have to say my little caveat. And those studies will be beginning sometime starting April and onwards.
Dr. Van?
I just have a quick kind of comment for everybody to kind of ponder, and related to this question of children and young adults having potentially mistrust in vaccines in the future. I wonder if that might be in part due to the specific nature of COVID, in the sense that, like, you know, it was mostly seen as a disease of high mortality for older adults, and for young adults, there's also a component of adolescence that they see themselves as really invincible and vulnerable, right? And so some of that might come into play as well. And the question of whether or not those kinds of attitudes in adolescence and young adulthood now carry on into the future when they have their own children, I think is a big question mark. Yeah.
Bien, merci. Je pense qu'il est temps. On pourrait peut-être passer à la table pour le lunch. It's time for lunch now. I think we can move to the table, and then we can jump to the next session. Thanks a lot for all the speakers. Thanks.